Today's conversation with all of you is about service and system fault lines, opportunities for community engaged research in public health and policymaking. I'm thrilled to be able to brainstorm alongside Dr. Shore and colleagues of ours at Autistic Adults and other stakeholders engaged together. So what we're going to share with you today are some of the things that we have learned through a PCORI-funded engagement award. And our team involves both myself, Dr. Shore, and a broad variety of autistic adults and care partners who have worked closely with us. So this is not just our work, it's a shared collective body of work, which continues today. ASET is continuing to collaborate with Drs. Brenna Maddox and Sherry Yeager-Hyman on a $9 million suicide prevention PCORI comparative effectiveness research project. So we're starting to address some of the goals that autistic individuals identified as priorities. So when we think about the title here, I really appreciate Dr. Carper's idea of talking about fault lines. Fault lines are powerful places on our planet that result in both destruction and creation at the same time. I had the privilege of growing up in Hawaii, and Kilauea and Mauna Loa were active volcanoes when I was a child living there in the 80s. And these represent images from Hawaii, and they're very dangerous and beautiful places all at the same time. So when we think about what we're sharing, both from our ASET work and all of the previous presentations that started this morning, hearing from autistic individuals directly, ending with what autistic individuals are prioritizing, and then how to link all of those things, we'll talk about maybe some opportunities for forward-thinking next steps. So main point number one, growth may be painful and disrupt the status quo when we think about volcanoes and with any sort of large changes at fault lines. And main point number two, the strongest force always wins. So who is at the table? What is the power of the people who are at the table? And are we thinking about power differentials as we develop research and the solutions? So today we're going to identify priorities that autistic people express for research and practice from this PCORI-funded engagement award and discuss opportunities for authentic and meaningful engagement in future research and service systems policy development. There's no need for me to review all of the things that we heard today from so many brilliant experts, both in the policy space and research and our autistic colleagues. But we know that we have disconnected systems as people age into adulthood. And these are problematic because the current systems and supports are not meeting the needs of autistic people for living a healthy and balanced life, things that they have goals to do in their life. And so we need to ask ourselves, well, what is it that autistic people want from a healthy life, from their life? What are their goals and priorities? Do they always fall neatly into these services and systems that we have within the United States? I think the answer is no, but let's talk a little bit more about this. I'll turn it over to Dr. Shore to continue on.
Oh, there we go. Hopefully you can hear me. And part of the reason that we have this disconnect is because we need to transition from the traditional medical model of disability, where it is the person's fault. We need to fix you as an individual. That model works very well when there is a physical problem in the body, such as you need a heart transplant or some kind of operation. But when we're talking about disability and differences, we need to take a look at society and look at how the social world can be made more conducive for autistic and, by extension, other individuals. So moving on to the next slide. As we think about priority setting methods in our asset work, we had three main ways of gathering information, 377 individuals to be specific, where we asked questions such as what is the most challenging healthcare issue facing autistic individuals, and through online survey, in-person focus groups, and large stakeholder meetings, we gathered this information. And if we flip to the next slide, we'll take a look at what the priorities are. And on the next slide, we see that what was most on the minds of autistic individuals, and again, learned by a study that was driven by autistic individuals with authentic and complete engagement of autistic individuals, it was mental health interventions and outcomes that bubble to the top. That was at the top of the priority. Access to healthcare and needed accommodations. And also pretty far up there were inequalities in gender inequalities in diagnosis, treatment, and sexual health. So moving on to the next slide, again, mental health was the highest priority, and one major focus was the impact of trauma on mental health in autistic individuals. And as you see here from these examples, as true to autistic individuals, we want things to be direct, very specific. So as you look at these respondents, I want you to write sexual assault on the whiteboard, straight up. Let's just be real. And someone else was diagnosed with PTSD, which may be true. However, it came from being persistently bullied. And on the next slide, priority number 2, social isolation, stigma, discrimination, and other forms of marginalization has a significant impact on autistic individuals. And sometimes I wonder, as we consider the mental health challenges autistic people face, and what often shows up as comorbidities such as depression and other situations, the question to ask is, what would the rate of, say, depression be in the typical population if the typical population had the same experiences as autistic individuals? So as we move on to priority number 3, there was also a lot of focus on self-managed interventions, making these interventions available within the community, perhaps without having to go through all of the, as was mentioned a little bit earlier, the Byzantine maze and challenges that we often face when we seek medical help. And now I will turn you over to Teal for mental health priority number 4.
Thank you, Stephen. So our 4th mental health priority that we learned about was understanding long and short-term negative side effects or adverse outcomes of currently recommended therapies and interventions. These included both pharmacological approaches, so medications people mentioned being on for a number of years. And as we talk about autistic adults aging, many individuals are placed on medications at a young age and continue to remain on those medications for quite some time. The average age of the people responding to our survey and in our focus groups was 40 years of age. And that meant that many of these individuals had been on some medications for quite some time. People wondered about the long-term use of those drugs on increased risk of fractures, cognitive decline, and other types of side effects that are not evaluated in autistic people. And these medications are often not evaluated over such a long period of use. So we need more information about that. Further, some individuals mentioned that some current therapies might not be promoting mental health, but might be impacting negative mental health through promoting stigmatizing beliefs or promoting exclusion. And so we need to be aware that the way in which our current therapies are impacting autistic youth may translate later into long-term mental health outcomes. We don't know this for sure, but the recommendation was to better understand that. Mental health priority number 5 was to better develop measurement tools that help us describe and quantify autistic quality of life. We heard that current quality of life metrics do not capture what autistic quality of life means. And I'm proud that UCLA and in their current granting program have supported an autistic quality of life study, a small one, to better understand what this means from the autistic perspective. We further need better measures of depression, anxiety, social well-being, and sleep. How are we capturing these priorities as people age? We know that sleep is an indicator of both physical and mental health, and yet is something that is reported as challenging for many individuals. So how are we addressing sleep? How are we measuring sleep? How are we asking about sleep? And as you can see from the quotes here, we need to measure the interests and priorities of autistic people. And we also need research into what creates a successful outcome as defined by autistic individuals. So the top priority outcome that we really need better measurement tools and data on is on quality of life, endorsed by 95% of the survey participants who shared their priorities and preferences with us. Anxiety, depression, social well-being, and sleep were also top priorities. As we move on to other top priorities, these have not yet been published. These are in preparation. We're working with our autistic partners to write these articles. Access to healthcare came up as our second main area of need. And a lot of the qualitative components that we heard, and as we've all heard here today, is around system navigation. So autistic individuals identified that family, friends, and social workers and other caseworkers help autistic individuals navigate healthcare systems and obtain access to healthcare. One respondent noted, though, that doctors and others can serve as barriers to system navigation. So doctors and psychiatrists tell somebody that they might be, quote, too high functioning to have a caseworker. And meanwhile, the individual is still having difficulty due to executive functioning challenges to know what the next steps are for their care. Another respondent shared that their providers talk about patient-centered care, but don't actually work with people to identify what the next steps are. So really working to help people navigate. And this is something that Lindsay mentioned, as well as many others earlier on in today's set of panelists. And then people need different types of supports. They don't need a one-size-fits-all model. And so one individual shared, I can drive myself, but I need help picking out a doctor in the first place. And sometimes making the appointment is hard, so I need my parents to help me with calling the provider. So how are we individualizing the types of supports that people need to maximize their independence, but also support them where they're needed? A second main area that came up in access to healthcare is on the provider's knowledge of autism. This is not new. This is something that Christina Nicolaitis and Dora Raymaker and others have identified in their stakeholder work. And oftentimes people indicated that providers did not communicate effectively or responded in a way that was disrespectful. So people also responded in the other way, that when they had a doctor who was willing to listen to them, learn about their priorities and what autism meant to them, that they were receiving better care. So we really need to focus on the people within the system as a next step. So people indicated that the doctor being calm and a good listener, taking time with patients and being willing to work with my special needs helps people return and want to come back for care. And here's a last negative example where somebody shared infantilization from providers, where providers treat them as if they're a subhuman, or maybe are promoting stigmatizing views of autism as soon as they learn that somebody's on the spectrum. So as I think Lindsay mentioned in the last session, we need to be better training people to engage with autistic people, particularly healthcare providers who work with adults who may just have had a lecture about autism in a pediatric care class and are not aware that these individuals are going to be seen, and quite a number of them, as people age. Our last priority area is on gender and sexual health. This broad area included a number of different components, and I don't have quotes here because I have some other slides. We have some other slides to present. But these gender and sexual health priorities included improved diagnostic assessment, in particular tools to assess autism in women and in those with diverse gender expression. Many individuals said that the diagnostic criteria were expressed differently by them, and they were therefore not identified at a young age. And the tools were seen as the problem. So how are we developing tools to address people who may not fit the autistic male perspective? Second, many individuals brought up sexual assault or unhealthy sexual and social relationships that sometimes resulted in harm or trauma. And so what type of research or data are we gathering on healthy sexual health and on sexual abuse? How are we helping individuals navigate those traumatic experiences? How are we tracking those types of outcomes? Those are important things to learn about, but we don't have a lot of data on, particularly in our large data sets. And last but not least, understanding how hormones change as somebody ages, particularly in autistic people, and how that might affect people's sensory experiences, perceptions of pain that changed as people aged, the influence of hormones on medication, and how those medications are absorbed and adapted by their body, and how hormone changes affect mental health. People indicated that they really had little idea. Nobody had talked to them about what aging was like and what the hormone changes might be like as they aged, and that they were different than neurotypical experiences. So we do need to hear more about that. So one of the things that we did at the conclusion of this project, which ran from 2017 to 2018, was we then looked at the literature again. What type of research had been done on identifying stakeholder priorities? And also at the same time as our project, Autistica had been engaging in their own work to identify research priorities, which is number one here on our sources. And their priorities also align with ours. Mental health being a number one priority, repeated a number of times in their top research questions. Sarah Cassidy's work on suicide prevention also aligns with our findings around suicide and understanding of suicide. And Liz Pelicano's work also helps see that we are having some alignment in what priorities people care about. So mental health, increased access to services, diagnostic supports for diverse groups, focus on person-centered goals and preferences, and self-management of health are all critical things identified by multiple priority-setting groups.
And what is particularly interesting is that we did not know Autistica was researching into this, and they did not know that we were researching into finding priorities as well. But we both came up with mental health as the top priority.
I think that's a critical thing. We're seeing alignment in all of these things. Thanks for that, Stephen.
Mm-hmm.
Stephen, I added a few slides here, so I'm sorry for throwing this off.
Oh,
I wanted to just point out that the disparities in access to these services was something that I think, Lindsay, you mentioned that we need more work on, is understanding how different groups access services and supports. And when we think about access to services and supports and the types of outcomes that we can measure in large scale data, we don't have all of these things available to us, but we do have information about access to different types of services. So I added a few slides here to just paint a picture of what does access look like for different racial and ethnic groups among adults on the spectrum. And in people aged 18 to 64 who were recipients of either Medicaid, Medicare, or both, we found that about 50% of them were Medicaid only, about 50% were Medicare only. But now when we start looking at racial and ethnic groups, that those differences were present, particularly Hispanic and Black individuals, as well as Asian and Pacific Islander individuals, were significantly more likely to just have Medicaid only, as opposed to being dual enrolled for Medicare and Medicaid in comparison to white individuals. And that those rates of enrollment, predicted probabilities of rates of enrollment, were exacerbated as we looked at different age cohorts. So for those in the younger age groups, dual enrollment was similar across those different race and ethnicity groups, but we start seeing trends towards racial and ethnic minorities being enrolled less than white individuals in both Medicare and Medicaid. So this speaks to that idea of access to services and systems and how certain marginalized groups may not be able to have the same level of access. And so how are we looking at equity? How are we looking at differences by geography, as one of the attendees mentioned? These are important questions for digging into some of these priority areas that autistic people mentioned. So now to talk about opportunities, I'll turn you back over to Dr. Shore.
Okay, great to be back, and some very important information, Teal, that you added into this presentation. So I'm glad you put those slides in. So thought number one focuses on what can we agree on and what do we need to collaborate on. An example of this is Dina Gasner's dissertation topic on autistic people's experiences regarding Social Security administration requirements for disability over at age 40. On the next slide, we have the tug of war between autism as disability and autism as identity. So we can agree on certain areas, such as autism is different, experienced differently by each individual. We have an extremely widely varying skill set, which can fluctuate given the circumstances. Incredible strengths, but with that comes incredible challenges. And a number of areas that we need to discuss include prioritizing autism as a disability for the medical model end of things, but focusing on what is needed as opposed to supporting strengths. And we need to have our systems recognize the importance as autism as identity as well. And not doing so magnifies challenges in mental health and societal exclusions. And we have intersectional identities such as gender, race, ethnicity, and others, which can further exacerbate challenges to access to supports and services. And we're back to Teal for thought number 3.
So thought number 3 on opportunities to consider addressing is that systems are built to exclude rather than include. I think we can all agree that there is limited system capacity in both people and in funding. Wait lists are long, demonstrating that this is in fact a fact. We also know that systems change slowly and they require data to change. We need data. So what we really need to discuss in terms of opportunities is whether we have the capacity to organize data collection both around the priority outcomes that autistic people think are needed and across the things that might be indicators of those priority outcomes across multiple systems that people might be in. We also need to discuss whether we have evidence and models of what successful systems look like in other countries. So we often think that, what do we need to change in our system? But there are other models. And so how are we building on evidence of other systems that have done this successfully? And last but not least, because we have limited system resources and people and funding, autistic individuals have asked for tools to self-manage their own health and well-being through community available supports, evidence that allow them to self-manage their health. How are we promoting people's self-determination and tools or toolkits to develop peer supports and other resources so that they can do that outside of a medical system? And then thought number 4 is we've talked a lot about mental health as a priority. And then we've seen in previous presentations that there's physical health outcomes that differ in different groups, but mental health is related to physical health. And even though people prioritize their mental health, when mental health is poor, all other things tend to go downhill. But our systems separate these two. So when behavioral health systems are not linking with developmental disability systems within states or the medical systems of care and people are being bounced around, we have a disconnect in how our bodies function. We need people who are addressing both. And we need to discuss how to frame mental health, not just from the negative health outcomes, but also as a component of healthy living. So living well is having housing, having meaningful employment or a vocational interest, having resources to live. And so how are we thinking about other indicators of mental health at the system level? And so in summary, autistic adults really want research that supports their personal goals and ability to self-manage their health. And they want society and the systems in them and the people in them to better support, communicate, listen to their goals. And improve the way that those systems communicate and the way that people can access those resources. So I'll go ahead and stop now, and we are available for questions in the last few minutes.